All right. Hi, everyone. Hope everyone's having a great day. I think we'll get started in the interest of time. I'm just going to introduce Andrew Holcomb, who is the moderator for the session, but who also organized this STAR panel. And he's from Nebraska, and I'll hand it off to you, Andrew. Thank you for organizing.
Great. Thanks, Tony. Thanks, everybody, for taking time to join us this evening. I'm really excited for the presentations tonight. We have a great group of panelists, as Tony mentioned, and so I'll make some introductions, and then I'm going to hand it over to them to go ahead and get started with their cases. So we have Annie Morocco and Michael Topf from Vanderbilt University. Is Dr. Topf on yet? I haven't seen him.
He and I were just finishing cases. He should be up
Okay.
shortly. I think we're going second, so he knows he'll be here by then.
Okay, perfect. We also have Dr. Colleen Hochfelder with David Forner from University of Michigan, and Justine Felteos and Alan Fang from Mass Eye. So thank you all to the fellows and their faculty mentors for preparing these cases. And then we're especially honored to have two expert discussants, Dr. Maribel Sagisevi from University of Vermont and Dr. Dawood Sirjani from Stanford University, who are going to provide expert commentary on the cases. So without further ado, I think we have Colleen going first. So if you want to go ahead and share your slides and take it away, we'll have 20 minutes in total for each case. We'll try to wrap up sharply at 7. I will say also, if you are not speaking, please try to mute yourself.
Okay, perfect. Thank you. Hi, everyone. My name is Colleen Hochfelder. I'm one of the fellows at University of Michigan, and I'm happy to be presenting this evening on behalf of University of Michigan with the faculty mentorship of Dave Forner. So thank you for having us. Ooh, let me figure out how to advance. We have nothing to disclose. So briefly, here's our objectives. We'll go through a case and then we'll use that as a jumping off point for some interesting discussions and literature review regarding topics including the clinically node-negative neck management in major salivary gland cancer, adjuvant radiation for low-grade salivary carcinomas, surgical and other management of recurrent disease, and then risks and management of distant disease. So this story starts off with a 28-year-old gentleman who presented with a parotid mass, which involved the parapharyngeal space. This was at an outside hospital, so unfortunately I don't have any pictures to show you. But this was a young, otherwise healthy gentleman who had an FNA and found a low-grade actinic cell carcinoma. He had no nodes clinically, so he appropriately underwent a total parotidectomy, parapharyngeal mass removal in March of 2019 and had reportedly some negative margins at that time. So this leads into the first discussion point, which is management of the node-negative neck in low-grade salivary carcinomas. So there is some data to think about when guiding this decision making. Vora et al. Reviewed the National Cancer Database and looked into the rates of occult nodal metastases. Their cohort included 6,977 patients. Among these, only 8.2% of low-grade tumor patients had occult nodal metastases versus 30.9% of the high-grade tumor patients. Specifically looking at low-grade actinic cell carcinomas, there was a very low rate of 4.7% of those patients had occult nodal metastases. Elective neck dissection was not associated with an overall survival benefit among these, with an adjusted hazard ratio of 1.10. In parotid malignancies, the nodal metastases were found to be most dependent on histology and tumor grade, with high-grade tumors in certain histologies, such as salivary ductal carcinoma and adenocarcinoma, having higher rates of occult nodal metastases.
Can I stop you for a second,
Sure.
Colleen? So I want to just pose a question to our expert discussants. How do you approach the clinically N0 neck in salivary malignancy? Do you base the decision on grade alone, or are there other features on imaging about the primary tumor that you take into account? What's your general approach?
I'm happy to start. One thing I wanted to mention, Colleen, if you're intending to share a presentation, I wasn't seeing it. I don't know about anyone else.
Oh, can you guys not see my slides?
I can see the slides.
Oh, okay. I might just be on the wrong view. My apologies.
Oh,
Um,
okay. Yes, I am showing
I'll-
things.
okay, perfect. So if one knows what the diagnosis is of the mass, then that's obviously very helpful. So to your point, if I'm aware that it is a low grade salivary gland cancer that has a low risk of metastasis, um, I wouldn't necessarily do an elective neck dissection. Obviously, I'd be very careful to evaluate whatever imaging they have, and I often do in an office ultrasound to further sort of confirm that they do have an N0 neck. I think the problem is that oftentimes we don't have their definitive diagnosis pre-op. You're often working with a sump or, salivary gland neoplasm of uncertain malignant potential. And then that makes it a little bit harder to decide what to do with the neck. I think some folks, including myself, may use some frozen section in that scenario. If this is a parotid tumor, you can easily access some level 2 nodes, maybe send that off to pathology. And if they see tumor, then, you could do a completion neck at the time of surgery.
I agree with you, though. I do this pretty much the same thing. It really depends on the histology pre-op. And I have a unique practice at Stanford where I get an MRI on all parotid tumors. And it really helps me because if the pre-op cytology is not, very accurate on whether you're dealing with high grade or low grade, then I rely on intraoperative frozen section of the primary specimen, or more often, if I don't rely who's reading at frozen sections, I go for a node and in level 2 nodes and submit that because it's really easy for a pathologist to say cancer or no cancer in a node, which by definition makes it high grade. So I rely on that a lot too.
Would you clarify, do you get MRIs on biopsy-proven benign lesions as well, or all parotid malignancies?
And no one sees me unless they have an MRI up front, including pleomorphics, which is kind of nice because you can really document what you're starting with. And if it turns out to be a high-grade lesion, as the workup goes, my radiation oncologist requires an MRI to make sure there's no perineural along the arcotemporal nerve for a parotid, which really impacts where they boost their radiation for adjuvant radiation post-op.
Great. Okay, go ahead, Colleen.
Perfect. Thanks for those insights. So this is another study that kind of looks into some of the same questions in the clinically node negative neck. Yan et al. Performed meta-analyses of 51 studies and included 11,698 patients and found that occult nodal status varied largely based on histology type, just like our experts are discussing. So on the left, we can see a forest plot comparing high-grade and low-grade tumors, and they found a higher relative risk for high-grade tumors compared to low-grade. They had a similar forest plot that I didn't include that showed an increased risk for T3 or T4 tumors compared to lower stage tumors. When they looked at histology among their patients, they found that acinic cell carcinoma had about a 17% overall rate of occult nodal metastases, and they did see that certain histologies were a driving force for occult nodal mets. So certain pathologies like salivary ductal, undifferentiated carcinomas, carcinoma X, adenocarcinoma, not otherwise specified, had a much higher rate of occult nodal metastases. So some of these data play into some guidelines that are out there, including the ESMO 2022 guidelines for node negatives neck. They leave it a bit open and similar. They do support an approach similar to like we're discussing of performing a level 2 neck dissection at the time of your parotidectomy and sending frozen analysis of any grossly concerning lymph nodes with a reflex further elective neck if you do see carcinoma in that node. But they do leave it open-ended, so they also recommend either considering observation or just going for the neck dissection. The ASCO 2023 guidelines recommend elective necks levels 2 through 4 for a parotid malignancy if it's high grade, or T3 or 4 disease for the clinically node negative neck. Okay, so going back to our case, this gentleman, as we underwent a surgery, had negative margins. About a year later, he represented with a post-auricular mass, and FNA again confirmed low-grade actinic cell carcinoma. At that time, he underwent radiation therapy and received 70 gray to the left parotid bed. I do not have any records of why that was the treatment approach at this time, but that is what happened. He had persistent disease after radiation, which was again biopsied and found to be actinic cell carcinoma. At that time, he underwent another 70 gray of proton radiation to the parotid bed. After his second round of radiation, he was found to have persistent disease now involving the skin, which was wide local excised and reportedly had negative margins at that time and confirmed still a low-grade actinic cell carcinoma. He underwent an additional 60 gray of proton radiation adjuvantly at that time, completed in January 2023, and had persistent disease on his post-treatment PET. At that time, he transferred his care to the University of Michigan.
So, Colleen, do you know any other pathologic features about the initial tumor resection? Was that pathology ever re-reviewed or obtained? Even
I have his chart open right here. We did re-review it here, so we agreed that it was a low grade. I'm not sure if what all we got. Let me look. So we got a CT guided biopsy of one of his recurrences and re-reviewed it and confirmed it was actinic cell carcinoma. We did get a portion of his initial surgery, which we at one point used for some additional testing, which we'll talk about later. But I don't think I have any other pathologic information.
T classification, LVI, things of that nature.
No.
Yeah.
I don't have that. And we requested to try and get op reports. I have some clinic notes from that provider that just say they underwent surgery, but no further details of the surgery or how things looked grossly in the OR.
So to summarize, they had one surgery and 2 rounds of full radiation, one being proton.
Yeah. So he had one surgery and then 2 rounds, 1 round of radiation, 1 round of proton, and then a wide local of some skin overlying his parotid, and then some more proton.
Was there any gene fusion testing, molecular marker testing, or anything like that, like to make sure it's not a secretory carcinoma who would benefit from?
There was not at that time, but we did perform that here, and we'll talk about what his mutation was later on, though it's not, it did not turn out to be a secretory carcinoma, but that's a great point that if you have an actinic cell who's acting a little funny, it's a common misclassification to think that a secretory carcinoma is an actinic cell carcinoma, and a good way to test for that is to check for a NTRK fusion gene mutation because there are some very good targeted therapies for that mutation. So that was a point I was going to make on a later slide, but we'll talk about it now because it's a great thought, especially in someone who has now received several modalities and is still having recurrent disease and is not responding as we would expect to the treatments that we're rendering. So he did receive a fair amount of radiation, and though not all of it was in an adjuvant modality, it does lead into a discussion about the role of adjuvant radiotherapy, specifically in patients with low-grade tumors. So we can talk about another great paper, which Dr. Sajasevi and the AHNS Salivary Gland section published, which was a large retrospective multi-institutional study looking at low and intermediate grade salivary gland carcinomas with 865 patients. Here they compared outcomes between patients based on margin status, which they stratified into negative, microscopically positive, and macroscopically positive margins. Negative margins were subclassified into clear with greater than 1 millimeter margins or close with less than or equal to 1 millimeter margins. In this cohort, 35% of the patients underwent adjuvant radiation. They found that radiation did not significantly impact local recurrence in patients with negative margins or close margins. Among patients with positive margins, adjuvant radiation did significantly improve local regional control. Among patients with low to intermediate grade carcinoma, with a 2% rate of local regional recurrence among patients who received adjuvant radiation versus 20% among those who only received observation. Okay, so this is our patient at the time that he presented at University of Michigan. And here are some of his images. So he had a PET scan, which showed that he had a parapharyngeal recurrence, which we can see in the bottom left there, which is FDG avid. In the space, you can see some surgical clips. So it is right in the area of where they had operated. There is some avidity in the GTS. He was DL'd and scoped and has had a number of images since that time, and nothing ever came of that. So I'm not sure why it is so bright, but it doesn't appear to be a malignancy because nothing has come of it in this time. In addition to his recurrent disease, you can see in the bottom right-hand corner, his condyles fractured off in the glenoid fossa, and on the 3D recon, it's a little hard to see, but it's cracked off and sitting in the glenoid fossa, right in the area of all their surgical clips and presumably where he got that 200 gray. Okay, so now that we're here, what would be the next steps in everyone's mind?
Certainly not more radiation. But and I got myself into the right screen. I can see your slides now. They're great.
Good.
So sorry about that. Yeah,
I hope you made it there in time to see my references to you.
Yes, appreciate that.
Good.
So you had kind of alluded to it already, but obviously, this is sort of not behaving like your classic low-grade tumor, and also B, ideally surgical resection, would be your front line if you could, but with that, prior surgery, radiation, and now the fracture and the ORN, that makes it really messy. So I definitely think utilizing some, next-gen sequencing and just, seeing what maybe targetable mutations there might be would be a good starting point. Not ruling out surgery, but it just would sort of proceed with caution.
Did you say you have another PET scan at this point? You have a PET.
I have one clip of it. I didn't
Right.
film
Okay.
my scans. Yeah.
So this is the only known site of disease, and this is a young patient, right?
Yeah, he didn't have any distant mets at this time and nothing lit up in the neck. And at this time, he's about 30 years old.
30 years old. Okay. Dr. Serjani, anything you'd add?
I agree with Mirabel that I would definitely do the sequencing, figure out what this responds to. But eventually, this patient is going to need a fibula. Any kind of additional systemic treatment with a condyle and ORN, it's a nightmare. So I would favor going to surgery and basically do resect part of the mandible, offer a fibula perhaps, and get this cleared out. And then you have, histology to work with, and you're safer once you do go transmandible. I mean, removing that the subcondylar and ascending ramus. It'll allow you to do a safer operation because with that much radiation to the site, that is way outside of standard of care.
That was exactly our rationale here as well. Since he had two indications for surgery and is a young, otherwise healthy guy, we opted to go for surgery and trying to get him the best functional and oncologic outcome that we could. So just like your thought process was, we planned for a 2-segment fibula and did our VSP, which was great, except he only had 2-vessel runoff and a congenitally absent posterior tibial artery on his leg. So we also always print our scapula model. And what we ended up doing was taking just a scapular tip and flipping it so that the tip of the scapula sits up into the glenoid fossa for him. Cleaned out his parapharynx again, did a revision parotidectomy. At that time, given everything that had happened, the need to get vessels and the desire to never come back to this neck after so much radiation, we did do an elective neck dissection. The bony appearance was that of ORN. There didn't appear to be any bone involvement, but there was multifocal, kind of diffuse involvement of the parapharynx with severe radiation fibrosis and concern for tumor deposits. So on his path from this surgery that he had here, he had another focus of a cynic cell carcinoma with vascular involvement. The margins were negative on that cancer that was cut out, and kind of supporting the other data that we've talked about. Despite this being aggressive local regionally with multiply recurrent disease, he didn't have any positive nodes in a 1 through 4 neck dissection that was performed at that time. Unfortunately, he was doing well after surgery functionally. His jaw was better, his pain was better, mouth opening is better. And then about a year later, he developed another recurrence. So he has this soft tissue deposit in the parapharynx there that the arrow's indicating, as well as in the bottom image, he has a lytic lesion in his manubrium that had developed in the interim, which brings us to the kind of the other modality that we haven't utilized yet for this patient in our multidisciplinary management of his salivary gland cancer, is to think about the tumor genetics. So we collected some of that initial tumor from his initial resection and sent that for next gen sequencing. It had a 0% AR, HER2 negative, but it did have a RET rearrangement with a fusion partner, with an unknown fusion partner, but a fusion protein. He was referred to medical oncology and started on selpercatinib. He also completed palliative radiation to his sternal bony mets. That was about a year and a half ago, and he's been doing well with a complete clinical response in the parapharynx and nothing visible, not having any pain, doing well functionally without pain concerns. And his subsequent CTs of the sternum and those bony mets have been stable without any progression since starting the selpercatinib.
Yeah, I think the finding of vascular invasion maybe tips to something that could have been missing from the initial pathology. LVI was something that Dr. Saji, your study, I think the hazard ratio for local regional recurrence was over 7. And so that could certainly be something that would predict an adverse outcome like this. I'm interested, you also mentioned, I think, that the nerve was spared in your operation. Is that right?
Mm-hmm.
And was that particularly scarred in? What was the experience like in dissecting that?
That is a great question. I don't know if Dr. Forner recalls.
Yeah, we largely didn't even need to find it. Stayed on mandible, and all the tumor involvement was deep to that. So we just stayed on mandible, lifted it all up, and took that out.
That's great. For the panelists, if there is, question of scar versus tumor in the area of the nerve in a case like this, you've used radiation supramaximally, right? This is radical surgery, probably the last operation you're reasonably going to do. Do you have a similar approach to the nerve that you might otherwise have in a case that doesn't have this history? Or would you be more apt to take a nerve if it's scarred in, if you can't get a good margin around it?
For me, it really depends on the histology again, and if the nerve is working, and surgically you're not going to provide a negative margin, and you're going to need radiation, and you can't tell if that's scar or tumor. In this case, they did the right thing because you're far away from it. Um, I do have a threshold to sacrifice the nerve if I think there's cancer in it, or if it's just scar tissue, I'll dissect around it. And but if it's palliative and the nerve is working, and you're not going to clear the margin elsewhere, just leave it alone. Not even, consider not even operating. So that's a really tough question. It depends on the patient and the situation.
Yeah. Okay, go ahead, Colleen.
Perfect. Um, so this patient ultimately developed distant metastases, which is pretty uncommon for especially a low-grade actinic cell carcinoma. In thinking about what data exists about risk factors for distant metastases, Mimica et al. Reviewed 884 patients at a single institution. 137 of those developed distant metastases, and they found a very low rate of actinic cell carcinoma. Only 8 out of their cohort were patients who had actinic cell carcinoma that developed distant mets. The median time from diagnosis to developing those mets was about 17 months. That's a very small number to try and figure out risk factors specifically for that histology type, but amongst their larger cohort, the independent risk factors for distant mets were tumor grade, higher T stage, and positive nodal disease at the time of diagnosis. This was where I was going to make that mention of keeping in mind to test for that NTRK gene fusion to make sure you're not misclassifying and dealing with a different histology than you think you are, because that does lead to the misclassification of secretory carcinomas as actinic cell carcinomas. The next thing to think about is the targeted therapy that he was started on. So he received selpercatinib. This is a highly selective RET inhibitor involved in ATP competition. The efficacy and safety of selpercatinib was established during the Libretto 001 trial, which was published in the New England Journal in 2020 and led to the rapid approval by the FDA of selpercatinib for non-small cell lung cancer and solid tumors that harbor a RET fusion mutation. As a reminder, the RET proto-oncogene encodes a transmembrane receptor tyrosine kinase that is involved in normal embryologic development. Fusions between the sequences that encode the kinase domain at the terminal region of RET and various upstream gene partners lead to abnormal expression of chimeric kinase fusion proteins. Selpercatinib is a highly selective small molecule inhibitor of RET kinase with a specific potency against diverse RET alterations, including fusions, activating point mutations, and against predicted acquired resistant mutations, but it does spare non-RET kinases and other non-kinase targets, as opposed to some of the other small molecules out there that can target RET. So it's kind of unique in that it targets only the mutated form of RET. So the Libretto 001 trial explored the efficacy and safety, mostly among non-small cell lung cancer patients, but it did include some other solid tumors. They found 68% of the lung cancer patients who received selpercatinib were progression-free during the interval of the trial, with a median progression-free survival of 18.4 months. They did include other solid tumors, as I mentioned, including 4 salivary gland tumors, which led to the FDA approval of the use of this medication for any solid tumor that harbors a RET fusion mutation in 2020. They also included 65 thyroid patients, which they published separately and led to approval for the use of RET mutated thyroid cancers. There have been follow-up trials since that time, including Libretto 531, which considered RET fusion mutated medullary thyroid cancer specifically and led to FDA approval of it in the setting of medullary thyroid cancer last year for adults and peds.
Okay, thanks, Colleen. I think we're about 30 minutes in, so I'm going to move us along, but a really challenging case, one where you wish that they could have been referred earlier in that disease course, of course. It's really tragic to see the complications that they suffered from it. And I think one of the last discussion points is just it's very challenging decision about how to frame that operation to that patient, right? They have possibly resectable, possibly curable disease, but in reality, with that much radiation with multiple prior recurrences, it may be best to consider that more of a palliative operation. And so they need to understand the risks associated with it, and it's a controversial operation to do. In a young person like that, I think it sounds like you did the right thing, but it's not an easy discussion to have with the patient in terms of framing what their expectations are. So thanks again for sharing that, and we'll move on to Annie.
Thanks for having us.
Thank you. Yeah. So I will get started with our presentation. So similar to Colleen, we have a young patient, 24-year-old female. She initially presented with 3 years of what she described as left-sided intermittent neck mass. At the time, she was 34 weeks pregnant with her second child. Otherwise, medical history is non-contributory. On exam, she had this mobile 3 centimeter mass in the left neck, a level 2 node. And on your NPL exam, she has some fullness of the left base of tongue. The scans are rolling here.
And can you go to on the sagittal where it extends most anteriorly? And can I ask for our expert discussants to just describe what do you see on the imaging that is of great interest to you? Anything stand out that you want to mention?
Yeah, that looks.
No, please, please.
No, was that Andrew? Was that meant for one of us?
Either of you, yes. Go ahead.
Oh, okay. Yeah. So yeah, just as you pointed out for base of tongue, I think the sagittal can be very telling, and this looks like a very sneaky tumor. That enhancing mass is really extending deep and interior, definitely over the hyoid. So just thinking about in terms of surgery, surgical approach, what you're going to need to take and how you're going to reconstruct, like that's what I try to look at. So this is certainly a challenge.
Yeah, I appreciate that. And we will kind of elaborate a little bit more on the next slide. So she did have a biopsy and FNA from an outside institution that was reread here, lacking any clear high-grade features, but favoring mucoepidermoid carcinoma. So really kind of leading to discussion in terms of treatment options, any specific considerations in pregnancy, further workup. Do we want to move on this quickly? We'd really appreciate the opinions of our experts here.
How far along was she in her pregnancy?
She was 34 weeks when she presented here with diagnosis.
Wow. And she had a 3-year history of this neck mass, is that right?
That's correct.
I would wait till the baby's delivered because I don't really think you can put her through that prolonged therapy without impacting the child. And
yeah.
if it's a low-grade mucoep, you got time.
Yeah. And then kind of akin to what Dr. Sajdavi was saying, considerations for what surgery you would offer.
It would be pretty big. I would drop everything down. I'm sure your robot guys want to do this with TORS, but I would actually go old school, either a drop down, resect everything to a clear margin, and free flap for providing bulk there to avoid radiation. Well, actually, you got a neck positive, so it's a high grade. So you're going to need radiation regardless post-op. But you can have one of your TORS people go in and TORS this out, or do a tongue split transorally, or just drop everything down and resect it, put a free flap there, and radiate afterwards. But you're obviously going to need the neck dissection as well, and possibly bilateral neck dissection.
And I would mention from someone who does TORS, I would not approach that robotically. And as I had mentioned, I use the hyoid kind of as my criteria for whether a base of tongue tumor would be favorable from a transoral approach. And so if you have tumor that's sort of sitting by the hyoid or sort of crossing anterior to it, you're just not really going to be able to get an adequate exposure and margin with robots. So I agree with the open approach.
Thank you for that, because there are some TORS people that would approach this. I mean, the easiest way is just go through like a cyst-rung procedure, transcervical, and resect the hyoid and that entire area of the base of the tongue. And you're going to need access transorally as well. To limit morbidity, you can just take everything out that way and do your neck dissections and radiate.
One question was, did it extend, significantly to the right aspect of the base of tongue?
I can go back and show the images again.
It's almost midline, at least
Yeah.
inferiorly, which is another, just concern about, obviously you can take one lingual artery and, one hypoglossal and have pretty reasonable function, but not both. So I would definitely, I don't know, review if I was, considering the surgery, would definitely review that with our neuroradiologist and really kind of look at the course of the lingual arteries and make sure that I felt like one could be spared. I mean,
Yeah, I agree. I also do tours, and I think if this were the more common HPV squamous cell carcinoma, this patient wouldn't get surgery at all, right? And that anterior margin is going to be very difficult to clear with the TORS approach. And so I think I agree exactly with what you said. Okay.
Great. Yeah, thank you. So, we ultimately, she was not at all interested in surgery. The risk of potentially a total glossectomy, taking both lingual arteries. So we
Yeah,
had
in my opinion, I did not feel comfortable not having total glossectomy on the consent because I was pretty concerned about the contralateral right neurovascular bundle. I was optimistic I could save it, but she had to be prepared for a total glossectomy, and she was not willing to consent to that, having just delivered her second child. So wanted to try something a little bit different.
Did she have a laryngoscopy with biopsy or just the FNA? Because I see the biopsy from the node was
Yeah,
somewhat.
just FNA at that time. She's just she's pregnant. I could have obviously at that stage in the pregnancy taken her for a DL biopsy, but we had an internal re-review of the FNA, and we're calling it basically an intermediate grade mucoepidermoid carcinoma.
So they were able to clarify that and define a specific histopathology.
They, yeah, discussed the tumor board, and they wouldn't 100% commit, but our pathologists and cytologists were calling it an intermediate grade mucoepidermoid carcinoma, fairly certain in the diagnosis.
Great. So she ultimately was induced at 36 weeks, delivered her second child, and then started with cisplatin and 66 gray of radiation. Her 3-month post-treatment imaging is here. She still has a persistently palpable node in the left neck level 2, and her CT demonstrates this. So we have continued to follow her. At about 5 months after completion of treatment, she was taken for a DL biopsy as well as an FNA of the tissue in the left neck. Both of those were negative for malignancy. She continued to get imaging, both PET and CT, all showed stable or decreasing size of both the base of tongue and the nodal disease until about 2 years post-treatment when there was noted to be enlargement on the scan. She was then taken.
I pose a quick question to the discussants. What are your thoughts on the inclusion of cytotoxic chemotherapy? The ASCO guidelines recommend against use of concurrent chemotherapy with non-operable salivary gland cancers. However, with this disease burden, the size, the invasiveness, the nodal disease, would you offer concurrent chemotherapy as well?
Well, she refused surgery, correct? So you really didn't, it's out, I mean,
Correct.
yeah, so you don't have a choice at that point. And I would have still offered her surgery because I think you would have been able to save one neurovascular bundle. And I would have been very clear on the consent that if I have to leave gross disease behind, um, your tongue may not work anyways after the fact. But reducing that tumor burden may have made the radiation potentially made the situation a little bit more treatable. But chemo rads up front for what she had, I mean, I don't think their outcome was that unpredictable.
That's fair. I think it's very fair. She really, I mean, even a subtotal glossectomy trach, like it, no, wasn't happening. I want to
Yeah,
try
that's
non-surgical
why the
therapy.
drop down will give you a really good assessment of, you can start the operation with assessing the neurovascular bundles. And if she says no total glossectomy, you can put it back up and say you can let this heal and then do your chemo rads. And imaging will give you a fairly good understanding of how close you are to the neurovascular bundle. And your coronal cuts on MRI should give you a pretty good prediction. I mean, obviously, you'll take the posterior branch of the lingual artery on both sides, but the actual artery that supplies anteriorly, there's a possibility that could have been saved.
And
Yeah.
sorry, this is Alan Bang, and I just want to say for these cases are so tough. I feel like we see this more commonly with adenoid cystic, kind
Yeah.
of in these base of tongue lesions, which are really, really tough. And I probably would have even recommended this exact same approach that you guys end up doing, like with trying for organ preservation first. I think sometimes we underestimate, especially for these highly functional patients, how big and devastating a total gloss is. And whenever I consent for a total gloss, I consent for a total Larry. I think maybe you could have saved the tongue, but I would have been, just like you were saying, I would have been very nervous about being able to do that. And then if their margins were positive and you're chasing, then all of a sudden you're in a situation where it's like this massive whack. And often for these adenoid cystic patients, we'll offer upfront chemoradiation instead, knowing that there's a large salvage option that should be able to provide adequate margin control, and having them try to preserve that organ. So I probably would have taken the same approach, honestly, instead of doing an upfront surgery, given the situation.
I will say she did get a second opinion from an institution in Boston that is not yours, and they recommended cisplatin and 66 gray radiation as well.
And I think this just really highlights to the importance of patient counseling and talking to them about all the possibilities and shared decision making. Because I do think that the surgery would have been a challenge, either potentially requiring subtotal total glossectomy or leaving tumor, neither of which are ideal, and particularly with what her priorities were. So very, very challenging situation for sure.
Yeah, I really appreciate everyone's discussion.
Yeah, we should, in the interest of time, we should keep going because it actually gets worse.
Yeah. So here I highlight kind of the next 2 years of her care with us, mostly driven by this last portion at 24 months when she had enlargement of the mass, was taken to the OR, ended up getting 13 pieces of biopsy, all of which still came back negative for carcinoma. So my question to the group was really how to manage a patient without a pathologic diagnosis, but really high clinical and radiographic suspicion for recurrence. We can discuss that or continue to move, but just in the interest of time.
I mean, I think your options at that point are going to be radical surgery or systemic therapy, and I don't think you can proceed with either of those without a pathologic diagnosis. So I think escalating your surveillance further if you're seeing changes. So And I've even seen people in more frequent intervals than 3 months if you're seeing things progress on imaging, so you can be ready to act.
Yeah. So she eventually now is 27 years old, 30 months post-treatment. We finally were able to get an FNA diagnostic of mucoepidermoid carcinoma. It's still fairly small, mass in the level 3 of the left neck. So once we got this diagnosis, we sent her for a PET. And in that interval of time, the mass had enlarged significantly. It went from sub-centimeter to 2.2 centimeters. So at that point, we got a repeat CT,
This is all in a
which
matter of a few weeks.
demonstrated that was the initial one. This is the newer one. Just rapid enlargement.
And sorry, did you, maybe you showed this, but was there PET avidity at the base of tongue as well?
I didn't show it, but there was.
Yeah, it's never been
Similar
crazy
to,
though.
yeah, similar to prior, unchanged.
Unchanged.
So now the snack mass is fairly rapidly enlarging. The consideration of going to the operating room, what structures will you need to sacrifice in the left neck? We don't have a diagnosis from the base of tongue. Are we going to resect that as well? Is there something else that we can do? A lot of discussion points here.
Show the axial one more time on the last scan.
I mean, that neck, it's a very ugly scan, you know. You do wonder a little bit about the carotid right there. Yeah, right there. And you know, you also worry about the biologic aggressiveness of disease, you know, like is surgery really going to do the job here? And especially when you're concerned about critical structures. So again, going back to the molecular testing and seeing if there's, you know, anything that you can give would be
Only FNAs at this point. You don't have tissue yet. Your initial diagnosis was an FNA and the recurrent cancer diagnosis was an FNA.
Could you, I mean, potentially get a core of that neck mass?
Definitely. It is rapidly progressing. So, you know, my experience with Tempest is it's, you know, still a 2 to 4 week endeavor at best. Or any other NGS.
Now you're really dealing with a palliative case. I mean, you're not going to get, you're going to have a microscopically positive margin at the very least around the carotid. And that's an area that was radiated previously, correct? So you're going to rely on a single modality treatment to palliate the patient, which is not going to do a whole lot. So molecular testing and systemic treatment is probably your best option.
So ultimately, we did take her to the operating room for the nodal disease. So we performed a radical left neck dissection. We did sacrifice several structures, but did not sacrifice the carotid and rotated a muscle-only pec flap up to cover that. At that point, we were able to get a diagnosis of the base of tongue lesion, again confirming mucoepidermoid carcinoma there. Just for sake of time, I can move forward. This was sent for tumor genetics, and here is what we have back so far. So she's got Tempest showing HER2 was 0, AR was negative. Interestingly, her CPS in the neck was high at 50. She subsequently went on to seek a couple of second opinions, and she is currently enrolled in a trial at MD Anderson, looking at this antibody drug conjugate. that's already approved in triple negative breast cancer as well as urothelial cancer and small cell lung cancer. But not a great story.
Yeah, thanks for
Really
sharing
tough
this case.
case.
Another really challenging scenario, right? And I think up front, the difficult decision between a very morbid operation and a young mother, right? Newly delivering child and then facing this um, versus a lower rate of control with non-surgical therapy. And unfortunately, she kind of took that option and it didn't work for her, but it could have. And then secondarily, trying to balance the desire to maintain safety in this person's neck in the setting of a rapidly growing neck lymph node or cluster of neck lymph nodes when you're worried about the delay in initiating and experiencing benefit from systemic therapy versus, the downsides of basically palliative operation that are going to cause sacrifice of various structures. So a lot of really challenging issues here, but some good learning points. So we're going to finish now with Justine, and we saved a slightly rosier case, I think, for the end, so we can all feel good as we wrap up tonight. But Justine, go ahead and take it away.
Okay, thank you. So today we'll be presenting a case that pertains to a 74-year-old gentleman who presented to our clinic with a right parotid mass and a frontal nerve weakness. So he has a past medical history significant for prior cutaneous malignancies treated with local procedures, as well as a CVA approximately 2.5 years prior, for which he was continued on aspirin, spends 6 months of the year down in Florida and doesn't endorse using any sunscreen. He came in to see us in June of 2025 with regards to a right parotid mass, which he initially noticed about 3 months prior. He was relatively asymptomatic, but 3 weeks before his consultation with our team, he started to endorse some pain where the slowly enlarging mass was and has a 1-week history of isolated right upper eyelid drooping. On examination, he was noted to have a right frontal branch weakness and a 3-centimeter parotid mass, which was mobile and free of overlying skin. No overt cutaneous malignancies were identified. He initially presented with a CT scan of the neck, which we will present next, and the chest was negative. So on CT, it was evident that there was a 3x3x3 heterogeneously enhancing solid lesion of the superficial lobe of the right parotid gland, which may have represented either a benign versus malignant etiology, and they recommended further tissue sampling, which is what we did next. So after he presented to our clinic, we ultimately obtained an FNA and an MRI. The FNA demonstrated malignant cells, which were consistent with a high-grade carcinoma with squamous differentiation. And here's the MRI, which again demonstrated a well-circumscribed, mildly lobulated 3.3 centimeter enhancing lesion of the superficial lobe of the right parotid gland, again consistent with the biopsy-proven high-grade squamous cell carcinoma, and had a little bit of fat stranding and no positive nodes on MRI. So with regards to the pathology result that we initially had obtained, it raised the question of differentiating a primary parotid squamous cell carcinoma from a metastatic cutaneous squamous cell carcinoma, as they can look similar on path. For this gentleman in particular, given the previous history of cutaneous malignancies and the fact that he was traveling down to Florida and wasn't using sunscreen, we ultimately did favor a cutaneous primary after tumor board discussion. They did do some stains, which again did point to a cutaneous primary. Most specifically, his S100, SOX10, and CK7 were all negative, which made it less likely that it was a primary salivary carcinoma. And he did have some P53 overexpression as well. He then met with our medical oncology team and radiation oncology team and was presented at our tumor boards. Again, it felt that his path was consistent with a cutaneous primary that was metastatic to an intraparotid lymph node. As such, the recommendation was that we would start with 2 to 4 cycles of neoadjuvant cemiplimab followed by surgery. And with this, we would do a repeat CT neck and chest after the first 2 cycles. And depending on the appearance of the mass and how it was responding to the first 2 cycles, then the decision would be made as a team to either proceed with surgery or do another 2 cycles of the cemiplimab. So he started with his first cycle on the 22nd of June, second cycle on the 16th of July. And then at that point, he was due to come in and see us for his visit after his second treatment. So here's a quick study looking at the metastatic disease cohort. It's a phase 2 study. Response was observed in 28 of 59 patients with a median follow-up of 7.9 months. They noted here an adverse event in 15% of patients, most notably diarrhea, fatigue, nausea, and constipation. However, 7% of patients had to discontinue their treatment due to the adverse side effects, which is what we will be focusing on next. So in July, after his second cycle of the cemiplimab, he started to experience intense flu-like symptoms and ultimately presented to the emergency department. He was found then to be febrile with a new AKI, pancreatitis, and transaminitis. This was all thought to be a result of his immunotherapy with a resulting capillary leak syndrome. He ultimately was admitted to the medicine unit, but unfortunately experienced acute respiratory decompensation, requiring intubation and an ICU stay. He was ultimately treated with conservative measures, most notably high-dose dexamethasone, and was discharged from the ICU back to the medicine floor in August, continued to do well, and was then discharged home. And for a quick word, the capillary leak syndrome, it's often associated with the cemiplimab. It's a rare but life-threatening immune-related adverse event where they get endothelial dysfunction, as seen here with the resulting sequelae. So then he came in to see us after discharge, and a new baseline MRI was obtained, which ultimately demonstrated marked interval decrease in the size and degree of enhancement of the superficial parotid mass, consistent with treatment effect. There was no evidence of any tumor progression or cervical adenopathy. So at this point, he was represented to our tumor boards, and given the intense side effects that he was experiencing from the immunotherapy, the decision was made to forego the next 2 cycles and to ultimately proceed with surgical management. In September, he underwent a right superficial parotidectomy with a limited level 2-3 neck dissection with facial nerve preservation without any complications. And at this point, his pathology, which is noted on the right-hand side, did not demonstrate any viable tumor cells, but it was confirmed that the excision did involve the area of previous FNA and the area of concern that he had presented with. With regards to his postoperative course, he ultimately had a small sialocele, which failed repeat aspirations. A small drain was placed under local anesthetic in clinic, and this has since resolved. He continues with close surveillance and is due for his postoperative scans in the next couple of weeks. And this is just a summary of the case presented today in his course.
Thank you, Justine. So the paper you presented, the 2018 paper, I think about 3/4 of those patients had distant metastatic disease. So
Yes.
this falls in line more with the Gross's Regeneron study published in 22 with the
Yes.
neoadjuvant protocol, which about half of those patients had pathologic CRs as yours did.
Yes, the highlight of that study was more so the fact that 7% of the included patients ultimately had to stop treatment as a result of the side effects from the immunotherapy, whereas that wasn't seen with the initial group.
And was this patient enrolled in AHN014 or was this just off trial?
Off trial.
I think this is before AHN014 enrollment started, I think.
Mm-hmm.
So for the discussants, how do you view a squamous cell carcinoma in the parotid in the setting like this? You know, I guess you didn't mention if they had a recent dermatologic evaluation with a concurrent squamous cell carcinoma, but you know, a history of cutaneous malignancies, presumably inclusive of non-melanoma skin cancer, probably including squam. So is that history sufficient to call this squamous cell carcinoma of the skin? Do you ever consider something a primary squamous cell carcinoma of the parotid? Do you rely on IHC? What's your approach to this?
We typically use, our best clinical judgment because, our pathologists feel that they can't really determine, at least that's what they tell me, the difference between the two. So, if they've, have a history of multiple Mohs surgeries in the past, even if their last, procedure was over a year ago, I feel like clinically that's sufficient for me to sort of say this is a delayed metastasis. And I feel like that's far more common than sort of a primary squame arising from the parotid.
I agree with that 100%. It's you have to presume it's a skin met if they have any history of skin cancers, or even if they go to the primary for freezing actinic keratoses off. And that's the more likely diagnosis. But there's a lot of high-grade, poorly differentiated lesions within the parotid that are really difficult to distinguish from skin primary. So this patient had an amazing response, and at our center, we do consider enrolling them into these trials, and they do great, especially at 74. It's the right thing to do.
And I think that's one of the main points we wanted to bring up with this, like in terms of like real world diagnosis and trying to figure out. This one is a little more straightforward in terms of their history and everything, but I feel like you'll often see those patients that you get the biopsy, just like you said, high grade carcinoma, high grade malignancy. There's no keratinization, no necessarily squamous differentiation. They don't have a history of skin cancers, and especially if they're younger, right? They're like say in their 50s. Like then what do you do? And that's kind of more of a discussion, and it really depends on a lot of clinical nuance, how exactly their tumor's presenting, and their also just a shared decision-making process with the patient, because a lot of times it's not straightforward to know if this is a salivary origin malignancy or if it's a squam met, because obviously you would want to treat those very differently. You wouldn't want to necessarily give them neoadjuvant treatment. You'd want to go straight to surgery if it was a salivary primary.
Yeah, I definitely agree with that. If it was sort of like high grade pathology with like multiple differentials, high grade mucoep versus squame versus whatnot. I agree. I think this surgery up front to establish a definitive diagnosis is still a very good option. And the other thing that to just one thought about that case is I think, Andrew brought up the AHN014 trial, and the spirit of that trial is sort of like you're looking at a resectable lesion, and if you are randomized to get neoadjuvant, like you're going to get the adjuvant and do the surgery, not sort of like a let's see what happens and then decide, which sometimes we've kind of fallen into that as well. And so I think if you, again, have like a resectable lesion and you're treating neoadjuvant, I think, the plan is sort of the plan should be, okay, after these, cycles, we're doing the surgery. Because I think some patients then, and you can, the trial allows you to sort of modify your surgery. If the tumor did respond, which is great, you may be able to do a more limited surgery than sort of the initial one. But still the intention is for surgery, because we do have some patients, they respond and they're like, oh, well, do I even need the surgery? And, and then you're kind of in this limbo. So I think setting expectations is a good thing to do in these circumstances.
And just for all the trainees, so HN014, it's open enrollment right now, phase 3 study for neoadjuvant cemiplimab. It's kind of the continuation of what Andrew mentioned for Neil Gross's paper, which was published in 2022, which was the phase 2 study that showed very positive outcomes, like a lot of complete responses. And so that's think it's going until like 2030, right? Like and it just started 2025. So data for that is going to be forthcoming.
One of the major differences to highlight too is that in this study, there's response adaptive surgery. And so if the tumor gets smaller, we're doing less surgery, which is, that's a whole new frontier for how we're going to respond to immunotherapy. And so it'd be really interesting to see what comes of this. And I'm curious to that end, you had a nerve branch at least that was not functioning at the time of the initial diagnosis, which would probably predict some degree of involvement. Not always, I suppose, but worrisome for that. And then in surgery, what did you encounter with the nerve?
So in surgery, there didn't seem to be any frank invasion. The only thing that made it complicated was that there was some scar and treatment effect around the nerve. But the decision was made at the time, given that we didn't know of any viable tumor cells, that we weren't going to do any facial nerve sacrifice. And ultimately, that seemed to be the good call given the final pathology.
Great. Any final comments from our expert discussants or questions from the audience? I know there's been some things in the chat. I think those have generally been responded to.
My last comment on this case is that oftentimes the patients do not have a significant radiographic response, but can have a complete pathologic response. So when you look at the phase 2 trial, it was probably just 60 or 70% of patients had some sort of partial response, and the path response was 51%. In our data using neoadjuvant cemiplimab, it's even lower. We see radiographic responses, about a third of the time, but we still have excellent pathologic responses. So just because the patient isn't responding radiographically doesn't mean that there's not effectiveness microscopically.
Okay, well, I just want
Andrew,
to, yeah, go ahead.
yeah, no, go ahead, Andrew.
I was just going to thank all of the fellow presenters and their faculty mentors and to our expert discussants. This has been a great discussion, some very challenging cases, and then a nice finisher with a good story. So I hope that all those in attendance learned something, and I just really appreciate everybody's time.
Thank you.
Yeah, I just wanted to thank you, Andrew, and everyone else that participated as well, including the attendees. Very, very challenging cases, I thought, varied cases. This set of presentations could have easily been at a national or international meeting, one of those like stump the professor type cases. And so I think for the fellows, kind of keep that in mind that, these aren't typical. I think we presented some very challenging cases with the goal of having all of those interesting discussions about nerve preservation and neoadjuvant and molecular testing and next generation sequencing and so on. So keep that in mind as you guys are studying through whatever source you're using to study as fellows to gain the knowledge you need for salivary gland, and you're probably seeing that through fellowship. Thank you guys so much. This was one of the most incredible sessions we've had all year, and looking forward to seeing you at the next one.
Thank you.